Yeah, thank you very much for the introduction. My name is Zahir, I'm an interventional radiologist in Oxford. I'm going to present our data on mechanical thrombectomy for iliofemoral DVT treatment. So we've heard from lots of talks that iliofemoral DVT obviously is a significantly associated with increased risk of PTS and PEs. Over the last several years, there's been an endovascular shift away from using lytic-based therapy towards mechanical thrombectomy alone, essentially eliminating the risk of systemic bleeding. We've heard very good outcomes from the CLOUT registry in the previous session, but the wider scope of evidence for MT is still fairly limited in clinical practice. So we looked at outcomes of MT for the treatment of iliofemoral DVT in Oxford. So just a brief on our Oxford DVT pathway. So we're a major tertiary referral centre. We'll get referrals electronically. If appropriate for intervention, they will be reviewed by both an interventional radiologist and a vascular surgeon. If a decision is made to treat, they'll be scheduled for thrombectomy plus or minus stenting. Post-procedure, they'll all undergo a standardized anticoagulation protocol and a duplex surveillance imaging. So in the context of stenting, we would survey them at 1 day, 2 weeks, 6 weeks, 6 months, and 12 months. And then we would consider re-intervention if we identify the problem on the surveillance imaging. So we keep a database of all our lower extremity DVT interventions. So in total, we had 101 iliofemoral DVTs treated with mechanical thrombectomy, and these were in 91 patients. We looked at outcomes of technical success, so complete or near complete patency of the index vessel at the end procedure, assessed by venography and IVUS. And then we looked at patency rates, so primary patency, assisted primary patency, and secondary patency rates. We assess clinical outcomes based on Villalta score and PTS severity, and we also present our re-intervention and safety profile. So this is a typical DVT case we would do. So patient be positioned prone, venography obtained from popliteal access. You can see clot from the femoral vein to the iliac veins. This is us doing mechanical thrombectomy with clot retriever. This is a clot we get out. We've restored vessel patency, but there's still obviously an MT compression, some iliac underlying stenosis or scarring. We'd stent it, good result. So baseline kind of overview is we had 91 patients. The majority are young patients, so 51 years. All had iliofemoral thrombus, and there were bilateral cases in 11%. There was concurrent thrombus in the IVC in 25%. The symptom duration is fairly mixed, but essentially ranges from anywhere from less than 7 days out to 6 weeks, and we treat all of them with mechanical thrombectomy. Our baseline Villalta score in our cohort was 11. So we performed the majority of cases using the clot retriever 13 French device. A very small proportion we'd also use penumbra indigo. General anesthesia in 58% of cases, and the remainder of local anesthetic or sedation. Generally, we'd approach from the ipsilateral side from the popliteal vein. In patients with IVC thrombus, we'd also perform embolic protection. So we basically use the flow retriever catheter disc off-label for temporary embolic. So we place a mesh disc in the patent segment of IVC, then we take it out at the end, and we historically used IVC filters. The majority will have venoplasty as part of the procedure, and we stented 64% of our cohort. We examined the thrombus chronicity on the back table, so how does it actually look when we're taking it out, and it's fairly mixed. It's split between acute, subacute, and chronic. Our technical success was 99%, so in all but one patient, we restored vessel patency, and that patient had a fairly chronic iliac occlusion, which we couldn't cross. If you look at patency rate, so this is using Kaplan-Meier survival analysis, so we just zoom into this. So primary patency is basically patency without any further intervention. Assisted primary patency is patency where there has been intervention, but not to the level of rethrombosis. And the secondary patency is patency with a re-intervention like a thrombectomy or CDT for thrombosis. So at 6 weeks, our primary patency was 86%, assisted primary patency 88%, and our secondary patency 94%. 6 months, again, primary patency 80%, so still very good. Assisted primary patency 85%, and sustained secondary patency rate. And again, we've got quite similar outcomes out to 12 months, although we do have a smaller number of patients at this stage. In terms of length of hospitalization, so 1 day, so most patients go home the following day. We've had 16 re-interventions out to 12 months, so rethrombosis treated with thrombectomy or CDT in 12 cases, and stenosis, with venoplasty or stent relining in 4 cases. In terms of our outcomes and kind of Villalta, so our baseline Villalta is 11. We had a statistically significant improvement in Villalta scores. So follow-up of a median of 5 months of Villalta score went down to 1. Most of our patients had moderate PTS at baseline, but at follow-up, the majority have absent clinically significant PTS, and we didn't have evidence of a moderate or severe PTS in our patients. Safety profile, so our mortality rate was 1% from a patient who had a PE post-procedure. We had a patient had unusual bradycardia relating to venoplasty that was self-limiting. We had a patient who had developed a stroke after an IVC filter was taken out. So in conclusion, MT for the treatment of iliofemoral DVT is showing good outcomes, at least in the short term, and reducing the severity of PTS. The findings mimic that of the CLOUT registry. We had some modest reintervention rates, but a lot of our patients have quite a large thrombus load, but our secondary patent rates are good. And we look forward to the Defiance RCT, which hopefully provide, level 1 evidence for mechanical thrombectomy. Thank you very much.
Thank you. Any questions from the audience?
May I ask a question? I'm always wondering, you said you have a 5.9% usage of off-label flow retriever discs? And also the IVC filter was used in 2% of the cases. But when do you decide to use it or not to use it? So do you have an objectifiable rule?
I think patients with IVC thrombus, if you have a significant column of thrombus and it looks fairly acute on IVUS or in transit, we just use a flow retriever catheter because it's so easy to use. You just access the other side, put up this mesh disc, do your whole clot retriever thrombectomy, because it passes through alongside the disc, and then take it down at the end. We have a low threshold now to deal with IVC thrombus.